Hello, everyone. Very good evening to all of you. I'm Dr. Sonali Agarwal, IFS Executive Member of MP Chapter. I welcome you all in this seventh webinar series of Polaris. This is the monthly webinar on imaging in gynec and infertility. For that, I really thanks to our hardworking leaders, Dr. Bela Bhatt Madam and Dr. Priya Chitawar Madam, for giving me this opportunity and having trust and confidence in me. I feel privileged to honor to invite our committed, knowledgeable, enthusiastic, dynamic leader, Dr. Bela Bhatt Madam. She is a chairperson of Foxy Imaging Science Committee. She's a lead consultant at Dr. Bela's Women's Hospital and Fetal Medicine Center, Andheri, Mumbai. She is FMF certified sonologist at fetal abnormality and FMF certified sonologist for nuchal translucency. She's Foxy certified trainer for ultrasound in obstetric and gynecology. She's a joint secretary of Association of Fellow Gynecologists at Mumbai. She's managing council member of ISPAT. She's a life member.
Fine, Sonali.
I welcome you, ma'am.
Thank you so much for, as usual, for kind introduction. Can we have all the, yes, thank you so much. So, I extend a very warm welcome to one and all as the chairperson of Foxy Imaging Science Committee, and along with on the behalf of conveners of this Polaris series webinar, both Dr. Priya Babe and Dr. Sonali Agarwal from IFS, who are two important and strong pillars for this series of Polaris series of imaging in gynec and infertility. And we all know this is a very, very popular series because so many people join, and they really are asking for the link also for this series, because we have the best of topics chosen for discussion, and we have the best of faculty to teach us so many important things as far as basics of ultrasound in infertility and gynae is concerned. So, I'm also extremely thankful to the Sagar Society for coordinating for this webinar. So, thanks to the President, Secretary, and all the office bearers of Sagar Society. Today, the topic that we are going to discuss about is follicle and endometrium, a mirror of reproductive endocrinology, and that is going to be delivered by none other than Dr. Sonal Panchal, who doesn't need any introduction either here or internationally. So welcome, Dr. Sonal Panchal. We are all always eager to listen to you.
Thank you very much, beloved.
Today we are very, very fortunate to have our chief guest, Dr. Alpesh Gandhi, and guest of honor, Dr. Shweta Gupta. So welcome both of you. As far as Dr. Alpesh Gandhi is concerned, let me first tell you that it was very, very kind of Dr. Alpesh Gandhi to join today despite his personal loss of his father. It's back. So, can you hear me? Hello? Yeah. So, our heartfelt condolences for your father, Dr. Alpesh Gandhi, and thanks for joining today to bless us all. Well, as we all know, Dr. Alpesh Gandhi is known to all of us. He is the past president, Foxy 2020, resource person for Foxy's GCPR on pregnancy with COVID-19, prepared national registry on pregnancy with COVID-19 infection, is resource person to prepare guidelines of establishment of obstetric HDU and ICU. We all know he has done some phenomenal work in the field of obstetric HDU as well as COVID-19 infection. And I'm very glad to inform you all that in the year 2020, when we all know we were all hit by the COVID, Sir was the president Foxy, and he was the one who started this entire idea of webinars and continuing medical education through webinars, because of which we could learn, we could connect with each other sitting at home, and we could learn so much in that 1 year. And following that, everybody has continued this webinar system, because with that we get to learn so many things. So thank you so much, sir, for introducing these webinars to all of us. Thank you so much, sir. Sir's CV is very, very long, so I'm not going to read entire CV. Sir has so many books, so many chapters and awards to his credit. So, sir, we would like to have your blessings to begin with this webinars.
Ma'am, sir is well-renowned personality all over India and abroad. Welcome you, sir.
Welcome. Sir.
Thank you very much, Dr. Introduction and for your regular communication for this me to father the strength of my my pillar.
Sir, I think audio.
This is my
there is-
first academic.
Sir, we
It
can't
is not
hear you
muted.
properly, sir. Your audio is little with disturbance. We can't hear you properly.
Now, can you hear me?
Yes, sir. Yes, sir. Yes.
Or still it is like that?
No, it is better. It is better.
Otherwise, I would have to change the place.
No, sir, it is better now. We can hear.
Okay. So thank you very much, Dr. Bela, Dr. Sonali, for the kind words and generous introduction. Thank you for inviting me and giving this honor. This is first webinar, first academic event after loss of my father, who was pillar, my strength. And I am thankful, grateful to all of you for your support in this difficult time and for your prayers for him. Really, it's a very good topic and a very interesting title of this. And I know this series of Polaris is very, very popular. And I would like to congratulate Dr. Bela Bhatt, the Foxy Imaging Science Committee for this series, particularly today's webinar on follicle and endometrium mirror of reproductive endocrinology. The subject is very, very close to my heart. Before I started working in critical care in obstetric, I was very fond of sonography and fetal medicine. And at that time, I took so many lectures with the title of sonoendocrinology.
Oh.
And this is the same thing. I know many faculties also ask my PPT on sonoendocrinology. So this is a subject very, very close to my heart. And this is the same, you have created a different title, follicle endometrium mirror of reproductive endocrinology. So it reminds me those days. We have very eminent faculties, Sonal Panchal, who is from my own city, Ahmedabad, and all of us have heard her a lot of time, and every time we are learning something new from Dr. Sonal. We have interesting panel discussion, and again a name is very catchy, very interesting. The eyes can't see what the brain doesn't know. Interpretation and follicular scans. It's a very interesting title, and we have eminent expert and moderators and panelists. So I am sure today's webinar, our delegates are going to gain a lot, which will be helpful in their practice. I would like to congratulate Dr. Foxy Imaging Science Committee, Indian Fertility Society MP chapter, Dr. Priya, and Sagar Obstetric Gynecological Society, President Secretary of Sagar Society, and all the delegates for this joint program. And I'm always happy to see when we are doing some joint academic activity, particularly academic or social activity. So it's good that we are continuing this webinar and sharing our experiences and knowledge through this webinar. So I again would like to congratulate all of you, and I hope you will continue this popular web series Polaris, and my best wishes to for the success of this webinar. Thank you very much for your invitation. Thank you.
Thank you so much, sir, for your words of wisdom. And once again, I thank for joining today and sparing your time today. Thank you so much, sir.
Thank you so much, Alpesh sir. And I remember when you were President Foxy, and that time COVID happens. And because of in your leadership, all the webinars have started. The trend has started with your this thing. So sir, wonderful leadership you have taken that time. And thank you so much for joining us. Thank you, sir.
Thank you so much. I am interested in attending the whole webinar, but because this subject is very close to my heart, but I would have to be live in between. So please pardon.
Thank you, sir. Thank
Okay, sir. No problem, sir. Thank you so much, sir. So now I really honor to invite our today's guest of honor, Dr. Shweta Mittal Gupta, madam. She is Secretary General IFS. She has done fellowship in National Board Reproductive Medicine MD and DNB. She is Treasurer IFS 2022-24, Treasurer AOGD 2021. She's convener SIG Reproductive Endocrinology IFS. She has received Economic Time Award for inspiring the obstetric and gynecology and IVF. She has received the Vigyan Vardhan Award and Dronacharya Award. She's icon of gynecology, MIC 2024. Foxy Ethicon Traveling Fellowship she has received. She's the first fellow, National Board Reproductive Medicine. She is credited for the first pregnancy from frozen thaw oocyte from North India. She's contributed to over 1,000 presentations and publications, teachers to fellows and postgraduate, peer reviewer of J Assisted Reproduction and Genetic, J Obstetric and Gynecology of India. I welcome you, ma'am.
Thank you, Sonali, for such kind introduction. And thank you, Dr. Bela, for being the chairperson of Foxy Imaging Committee, and Dr. Priya, who is the secretary, MP chapter of Indian Fertility Society, along with Sagar Obs Gynae Society. It's a very mammoth task to do these kind of programs. It's not easy. I can see Dr. Priya so keenly involved in this program, and what a fine tuning of the program which have been done. Series 7 have been done and many more to go. I think when we talk of follicle monitoring and endometrium, it is the benchmark. It looks so easy, right? We can see the follicle, but I remember when I started my fellowship, with Dr. B.N. Chakrabarti, and he put a small ultrasound machine just for my training. And every time then I started realizing, oh, it's difficult to focus a retroverted uterus. It's so difficult to focus on the endometrium, the left side, because the colon comes, always the follicle is missed. And then I would gather these few patients and then go to Shangmitra Didi, and I would say, okay, now you do it on the higher machine. You are so much more experienced. So I know that even if my 3 fellows measures the same patient's follicle, there will always be a discrepancy of 1 to 2 millimeter. Even the endometrium, I can make the endometrium look 6, I can make it look 6.5 and 7. So this looks simple. People think that lower end machines can do justification, but we will hear from Dr. Sonal. She's so experienced, a complete authority when it comes to follicles. So if I talk about the ovarian follicle, it is the story of recruitment to dominance to pathway to ovulation, and that is what possibly we'll be hearing, and how the endometrium dances to the interplay of the hormones which are released by the ovary, and how the sonologist or the gynecologist who's doing sonography picks it up and interprets that now it is fertile, now it is fertilizable. So I'm looking forward to it. Thank you, Dr. Bela and Dr. Priya, for initiating such a wonderful program, Polaris, and I'm looking forward to it.
Thank you so much, ma'am.
One more, yes.
Right.
So being the organizing secretary of our annual Congress Fertivision, which will be held on 6th, 7th, and 8th at Ahmedabad this year. So I'm inviting everyone to be a part of it. All the youngsters who are attending the conference, join as delegate and present your work. Today is the last day for early bird registration. So thank you so much.
Thank you, Dr. Shweta, for blessing us. Thank you.
Thank you so much, madam, for your blessings and kind words. Now it gives me a pleasure to invite our all-rounder, dynamic, hardworking leader, Dr. Priya Bhave Chittawar, madam. She's FNB reproductive medicine teacher, ex-faculty DM reproductive medicine, Foxy organized trainer in basic and advanced infertility management courses. She's a Cochrane reviewer and author. She's a secretary, MP chapter IFS. She's awarded with Dr. Pankaj Talwar Gold Medal in IFS 2022. and she's received Ironman triathlon winner. I welcome you, Priya ma'am.
Thank you so much, Sonali. And it is a great moment, really. Today is the 7th webinar of Polaris. And I don't want to stand between all the eager audience and Sonal madam, who is ready with her pitara of knowledge. And we are all wondering what new we will learn from you today, madam. But I can't start without giving credit to two people. One is, of course, Sonali, who month after month, she finishes the work of one webinar. And then immediately that evening, she starts coordinating for the next webinar. So I think big round of virtual applause for Sonali. And secondly, Dr. Tina, because she is like a rock. Every time that we are stuck somewhere, every time, even if I am not able to join, she will be there and she will be joining us as expert today. Sonal madam is busy with guests, but she has kindly agreed, and I know and I learned so much from you, madam. You never say no to any academics, even if it means inconveniencing yourself multiple times. Thank you so much, Dr. Shweta, for joining us. Your presence actually fills all of us with a lot of enthusiasm because we know that you are very busy with the Fertivision coming up. But you've taken out time. So thank you so much. And madam, over to you.
Thank you. Should I start, Sonali?
Yes.
Ma'am, I would like to invite our chairpersons, please, ma'am, if you give permission. So now I would like to invite our esteemed chairperson, Dr. Jagriti Nagar, madam. She is the president, Sagar Obstetric and Gynec Society. She's an associate professor, Bundelkhand Medical College, Sagar, winner of Durusha and Dr. D.K. Tank Award. I welcome you, ma'am. Next, our esteemed chairperson is Dr. Swati Patil. She is secretary of Sagar Obstetric and Gynec Society. She is the director of Kalyanika Hospital, Sagar, Madhya Pradesh. She is the treasurer of Jabalpur Obstetric Gynec Society in 1416 and joint secretary, special interest in high-risk pregnancy. Our third chairperson is Dr. Varuni Shukla, madam. She is MBBS MS FMAS infertility specialist. She's assistant professor in Shubharti Medical College, Dehradun. She's associated professor in Maulana Ambala. She is now presently working in Gynec and Obstetric and director of Vaibhav Memorial Hospital, Gwalior. So I welcome you, ma'am. I request our chairperson to introduce our today's speaker, Dr. Sonal Panchal, madam. I think they have not joined. So
I think that is fine, Sonali. I can join without an introduction. I can start without an introduction. Don't worry.
okay, ma'am. Ma'am, slight introduction. She's consultant, Dr. Nagori's Institute and Infertility and IVF, Ahmedabad, India. She's PhD in ultrasound in gynecology and infertility. So everybody knows, madam, and I just don't want to waste time, ma'am. I welcome you all. And can you start, ma'am, please?
At the outset, thank you very much to Dr. Alpesh Bhai, Dr. Shweta for their kind words. Thank you very much, Sonali, for this invitation again. And of course, thanks to Dr. Bela and Dr. Priya. By the way, I just want to tell you, Priya, it was probably not because of guests. In fact, I had written it was a family emergency, and I would really wish to have prayers from you all. Sir, Nagori sir was extremely ill. He is better now, but he was extremely ill. Because of that, I had said I don't want to continue longer till the panel. He's good now, but I know that you respect him so much. That's the only reason I'm telling you this.
Yes, ma'am. Our prayers with him. And we just hope that he recovers very soon.
Yeah, he is well now. We have brought him back to the to our hospital from the admission wherever it was. Thank you very much. So to start with, we are going to talk about a truly interesting subject, which is follicle and endometrium, a mirror of reproductive endocrines. We know that the menstrual cycle is a very delicately balanced orchestra of continuously changing hormones. And these reflect almost instantaneously as vascular changes and later as morphological changes in the uterus and in the ovaries. Since these hormones are affected by each other at different times of cycle, let us discuss this into different phases of menstrual cycle, just for the sake of convenience. We would say early proliferative phase, a pre-ovulatory phase, and a luteal phase. Starting with the early follicular phase, the hormones that are of interest at that stage would be AMH, androgen, FSH, LH, estrogen, progesterone, and of course, insulin resistance. I know that at that stage, when we get the blood test done or the infertility is the so-called infertility profile done, we also talk about, or we also would want to investigate about the thyroid and the prolactin, but I've purposefully not included this here since they do affect the reproductive system a lot, but they are not truly reproductive endocrines. Starting with AMH, we know that it is a marker of ovarian reserve. It is produced from the granulosa cells of the preantral and the small antral follicles, and it is used for predicting both over and under response to the controlled ovarian hyperstimulation. Antral follicle count and the ovarian volume showed significant correlation to AMH, and serum AMH levels have been shown to strongly correlate with the number of antral follicles in another study also. In a study done by us, where we compared AMH and AFC for two different groups, the normal controls as well as the PCO patients, for two end results, the number of oocytes retrieved on the ovum pickup and the number of follicles larger than 12 millimeter on the day of trigger, in both the groups, for both the markers, for both the end results, there was no statistically significant difference found. And therefore, we do believe for sure that for the normal controls as well as for the PCOS patients, whether you use AFC or AMH, since they are very closely correlated to each other, doesn't make practically any difference at all. AFC and AMH have been proved to be equally accurate in normal reserve and PCO groups. There was, therefore, the conclusion out of that study. In another study by Jayakrishan, it was shown that for the prediction of poor ovarian reserve, a model including AFC and AMH was found to be almost similar to that of using AFC alone, and combination of both the tests do not significantly increase the predictive power. AFC and AMH will not offer mutually exclusive information. So that brings us to understand that since AFC and AMH are very closely correlated, you can evaluate one of the two, and that means that you can definitely, for all practical purposes, replace AMH for AFC. So you can just get an AFC done, which would be enough for your practical decision making. The number of small antral follicles between 2 and 6 millimeters is significantly related to age and also independent of age to all the ovarian reserve tests, all the endocrine ovarian reserve tests, suggesting that the number of small antral follicles represents the functional ovarian reserve. But it is essential to count the antral follicles very precisely. Yes, it is true that if the number of antral follicles are up to about 12 to 15, in these cases, just scrolling across the ovary on 2D ultrasound is a sufficient assessment of the antral follicles. That means if the number of follicles per ovary, the number of antral follicles per ovary are up to 12 to 15, if you locate the ovary, then scroll out of the ovary in any one direction, and from there you are going to come back to scroll across the entire ovary until you lose the vision of the ovary. Don't come back, don't rotate the probe, eyeball and count the follicles. It is as accurate as 3D. But of course, when the number of antral follicles are multiple, that is when it is always better to use the sophisticated Sono-AVC software of 3D ultrasound. This color codes the follicles, and therefore it is easy. There's a least chance that it will overcount the same follicle over and over again. And for the follicles that are left out, you can use a post-processing, which would make the assessment of the number of antral follicles very precise. Sono-AVC not only gives you a precise counting of the follicles, it also gives you the size of the follicles and still takes lesser time to count and measure them. It is therefore, in cases of multiple antral follicles, we do prefer to use 3D with Sono-AVC to count the antral follicles if we are going to omit the AMH assessment. If talking about the antral follicles, androgen also needs a mention. We know that androgen is responsible for the recruitment of the follicle from the preantral to the antral follicles, and it also reflects as a high uterine artery resistance. If I say so, that means that AMH leads to, androgen is the cause and AMH is the result of number of antral follicles. But moreover, as mentioned here, it is androgen, which is so-called male hormone. It is responsible for increased tone in the muscularis of the in the smooth muscles all over the body, and therefore it also leads to increased tone in the muscularis of the uterine artery, leading to a high uterine artery resistance. And usually this is followed not only in the early phase of the cycle but throughout the cycle. That means that high uterine artery resistance throughout the cycle is a marker of high androgen, along with especially multiple antral follicles. Androgen is responsible for recruitment of the follicles from preantral to antral follicles. Therefore, as I just told you, an antimullerian hormone AMH is produced by the granulosa cells of these follicles. That means both androgen and AMH can be used to replace, both can be replaced by counting the number of antral follicles. Coming to FSH, it was used earlier for assessment of the ovarian reserve, and it negatively correlated with the AFC. High day 3 FSH is highly predictive of poor ovarian reserve and poor pregnancy rates, therefore, as we all know. FSH receptors are not present in the preantral and the small antral follicles, and the follicles become FSH sensitive at about 7 millimeter diameter and FSH dependent at about 10 millimeters diameter, which is called dominance. This is where I definitely want to give a little more elaborate understanding or a little more elaborate explanation of the same. We know that FSH, which is, if it is high, it indicates that the patient is an poor ovarian reserve patient. If the patient is a poor ovarian reserve patient, naturally it will be related, it will also show low AFC. And it is because of that the patient is called a poor ovarian reserve patient, and because of the aging ovaries and because of the aging oocytes, the pregnancy chances are less. Yes, of course, therefore, we know that high FSH is a sign of ovarian aging. But what is the sign that you would see on ultrasound? And this is something very interesting. We know that the follicles, they grow up to about 6 or 7 millimeter under the effect of androgen alone. Beyond that, they need FSH for the growth, initially because they become sensitive to FSH, but later because they become dependent on FSH. That means this is because of the development of FSH receptors on the follicle. Therefore, if you see a follicle which has already reached 10 millimeters or beyond on day 2 or 3, which is a baseline scan of the cycle, this growth of the follicle is not possible in absence of high FSH, and therefore early recruitment of the follicle is a sign of high FSH or high basal FSH, and therefore ovarian aging. Here, I want to again correct my sentence. I would not say it is a sign of high basal FSH. I would say it is a sign of a rising basal FSH. Very interestingly, therefore, whenever you see an early recruitment of the follicle, it means that the FSH level has started, the basal FSH level has started rising, and therefore on ultrasound, even before the FSH crosses that critical limit of 15 or 17, you can still diagnose that this ovary is progressing towards aging, the basal FSH has started rising, and therefore it is in these cases that no cycle should be missed. Every cycle is precious and should be used. If I say that it is the sensitivity of the follicle that can be to FSH, which can be predicted by the size of the follicle, I think this point also requires a little more correction here, and that is dominance of the follicle. When we say at 10 millimeters, this dominance is not actually the size. The dominance is the sensitivity of the follicle to FSH, and therefore it cannot be decided only by the size. Very interestingly, therefore, whenever you see a follicle on the baseline scan, which is 9, 10, 11, 12 millimeter, you should always put on a Doppler first. And as you put on the Doppler, look at the blood flows. If you are not seeing any perifollicular blood flow, as you see here, remember the perifollicular blood flow is only the blood flow which overlaps on the follicular wall. So here in this case, you are not seeing any perifollicular blood flow, which tells you that this is not a dominant follicle. Similarly, you are seeing another follicle also, which also doesn't show any perifollicular flow. But look at this. This follicle is larger. There's another follicle here far off, which is smaller than that. But look at that beautifully. It shows beautiful perifollicular flow, and it absolutely, the entire hilar flow is directed towards this follicle, which tells us, yes, this is the follicle to which FSH is reaching because the blood flow is reaching there. And therefore, that follicle has developed FSH receptors. And therefore, this is a dominant follicle. So the lesson important here is when I'm doing a day 3 scan, and if I'm finding a follicle which is grown beyond 9 millimeters, I must put on the Doppler only if it shows blood flows. This follicle shows blood flows. It is an active follicle of this cycle. Otherwise, it is a residual follicle of the previous cycle. If it is an active follicle of this cycle, that means the dominance has been achieved, which means that it represents high basal FSH. But if it does not show flow, that means it is not a hormonally active follicle, and it is not going to come in the way of your stimulation, and you can just ignore it and start your stimulation. So yes, apart from the hormonal assessment, it does also give you an idea as to whether this the cycle should be continued or not. So that is about the that is about the FSH on the baseline scan. That means that a follicle of more than 10 millimeters, or I would say more than 9 millimeters on day 2 or 3 of the cycle, indicates rising basal FSH, provided it shows blood flows also. And this means it would result into shorter cycles, and it may also be associated with less antral follicles. Just being a little more clear here, remember, you may also find early recruitment of the follicle in aging PCOS patients. In those cases, you would still see several antral follicles, but it is the early dominance of the follicle which indicates high basal or the rising basal FSH. Yeah, this is what I have already discussed, so I'm just going beyond this. And this is also what I have discussed, so I'm going still beyond this. Apart from the residual follicle of the previous cycle, which is identified by not only lack of flow, but also by isoechoic walls and anechoic contents. You may also sometimes find follicles with hyperechoic walls, low-level echogenicities, and scanty flow surrounding on your early follicular scans, and these on the early cycle scans, and these are residual LUFs, the luteinized unruptured follicles. Again, because it is not highly vascularized, that means it is not producing adequate hormones to affect the endometrium or the follicular quality, and therefore are not of clinical significance. In this case, also remember that if I told you that it is not producing adequate hormones to affect the endometrium or the follicular quality, you can check the bioactivity of these hormones by looking at the endometrium. Say, for example, even if I have not only LUF, but even if I have residual corpus luteum, if I'm seeing adequate flow, if I'm seeing a low resistance flow, that means it is hormonally active, which should be confirmed always by looking at the endometrium. If I'm expecting progesterone secretion from the residual cystic lesions, I will have a hyperechoic endometrium of more than 5 millimeter. If I'm expecting estrogen secretion from the residual cystic lesions in the ovary, I should check for the 999 endometrium to confirm whether the hormone produced by these residual structures are bioactive or not, and only if they are bioactive, they are of significance. Otherwise, you can just ignore them and continue with your stimulation. So that is about your baseline scan, that is about FSH, and along with that, I've also discussed as to what should be the interpretation if you have residual cystic lesions on the baseline scan. Coming to the luteinizing hormone. The luteinizing hormone, as we know, it acts on the theca cells. This helps conversion of cholesterol to androgen and progesterone. We all know about the 2-cell 2 hormone theory. It is LH which is responsible for theca cell proliferation. Theca cells constitutes the main component of the stroma, and therefore, if you find increased theca cell population, that means if you find abundant stroma, increased stroma, this may be an effect of LH, particularly so in the PCOS patients. This can be explained by insulin, which augments LH-stimulated androgen production by the stromal cells. Androgen in turn causes proliferation of the stroma and the theca cells, and this leads to increased stroma in the PCOS patients. If I say so, let's make it a little more simpler here. The insulin, it leads to increased, it usually is associated with hyperandrogen. It is this hyperandrogen which produces more number of which recruits more number of antral follicles from preantral, more antral follicles, that means more secretion of estrogen from the granulosa cells of those antral follicles. More estrogen leads to negative feedback to FSH, but a positive feedback to LH, leading to rise in the LH levels. Increased LH affects the stromal cells to lead to more androgen production, this androgen further leads to proliferation of the stromal cells and the theca cells and leads to stromal abundance. That means that stromal abundance is a very important and probably one of the most consistent features of high insulin and therefore PCOS patients. This abundance of the stroma can, if I say that the stromal cell constitutes of theca cell and the theca cell proliferation occurs because of high LH, whenever the LH is high because of the theca cell proliferation in the initial phase, these theca cells, which are the main component of the stroma, they try to accommodate themselves in the same stromal volume, and they would get more densely populated in certain nests, in certain pockets of the stroma, giving rise to patchy increase in the stromal echogenicity. Remember, the normal ovarian stromal echogenicity is same as that of the the normal ovarian stromal echogenicity is same as that of the normal myometrium. But if you find that the stromal echogenicity is more than that of the normal myometrium, this is what is reported as increased stromal echogenicity, and it represents stromal abundance. But this is a bit subjective because only if the myometrium and the ovarian stroma are equidistant to the probe, you can evaluate, you can compare the echogenicity. But if they are not at the same distance from the probe, in those cases, you may have to depend on more objective parameters. That's when you would you would find the longest section of the ovary, draw the circumference, measure the ovarian area, and ovarian area of 5.5 centimeters square has a good sensitivity and specificity to say that, yes, this is stromal abundance and this patient is a polycystic, this patient has polycystic ovaries. But if you want to more exactly measure the stroma, you should also calculate the follicular areas, deduct all the follicular areas from the total ovarian area, find out the stromal area, and the stromal area of 4.6 centimeters square also has a good sensitivity for the diagnosis of polycystic ovaries. But the ratio of 0.32 is even more reliable. The ratio of stromal area to the ovarian area, 0.32, is one of the most reliable methods to say that, yes, this is a polycystic ovary. I'm not saying polycystic ovarian syndrome. I'm only talking about the polycystic ovaries. Of course, both total ovarian volume and stromal volume during the early follicular phase are significantly higher in the women with PCOS. Stromal volume was positively correlated to the to the serum androstenedione concentrations in the patients with polycystic ovarian syndrome, and the stromal area to the ovarian area ratio also has a strongest correlation with serum androgens, especially testosterone and androstenedione and insulin. This makes us understand that all the major culprits of the or I would say all the major biochemical derangements of the polycystic ovarian syndrome correlate with the increased stroma, and LH being the most insulin and LH being the most reliable ones. Along with this evidence, also would say statistically significant relationship was reported between the ovarian volume and the stromal echogenicity with serum LH and testosterone and the degree of insulin resistance. And still one more evidence which says that there is the strongest correlation between the stromal volume and the postprandial insulin level in the PCOS patients. All this put together tells us that, yes, abundant stroma tells us LH is high, and it also correlates with the insulin resistance. But very interestingly, the LH is not just abundant stroma. LH is also increased vascularity. It is high LH levels, which is responsible for increased vascularization due to neoangiogenesis, catecholaminergic stimulation, and the leukocyte cytokine activation. By catecholaminergic stimulation and leukocyte cytokine activation, it leads to low resistance flow apart from the actual neoangiogenesis, which leads to abundance of the blood flow. That means that if you find in the ovary that the resistance index of the stromal vessels is less and the blood flow is abundant, these are the signs which tell you that the LH is high. And this is the sign which comes up even before, this is the sign which comes up even before the stromal abundance is documented. To make it all simple, let me put it this way. If I'm talking of LH, increased stromal vascularity is the first sign of high, and when the LH starts rising, and when the LH remains high for a longer period of time, that is when you would also get stromal abundance in the form of either increased echogenicity, increased stromal volume, or increased stromal area or increased stromal volume. And that means, these are the two signs of increased LH or high LH on the baseline scan. Along with that, it has also been clarified that stromal abundance also correlates with the insulin levels, and therefore increased stroma is also a sign of insulin resistance. Ovarian stromal flow in the early follicular phase is moreover also related to the ovarian response to the IVF treatment, or therefore that matter any ovulation induction protocols. That means that if the blood flow to the ovary is more, that means that the ovary is going to be a hyper responder or a high responder or a good responder. Ovarian stromal PSV, even after pituitary suppression, is predictive of ovarian responsiveness and the outcome of the IVF treatment. Those who had low stromal PSV in the early follicular phase were poor responders. Kopasik has shown a correlation between the ovarian stromal flow index and the ovarian response in the IVF cycles and the pregnancy rates. And the vascularity index, the flow index and the vascularity flow index, which are 3D power Doppler indices, which respectively talk about the abundance of the flow, the average intensity of the flow, and the perfusion, are also significantly related to the response to the ovarian stimulation. It is generally believed that with the increasing age, you are going to require higher doses for stimulation. This also has an explanation in the vascularity studies. It has been clearly shown in the 3D Doppler studies that VI and the VFI were 1 years of age. And this is the reason why it is these patients who usually have a poor response. Very interestingly, if I say that the patient's ovarian stromal vascularity correlates with the ovarian response, there are definite parameters on the 2D Doppler also, which tell us about the response of the ovaries to the ovarian ovulation induction or to the ovarian stimulation. The hyper responders usually have an RI of less than 0.58 and a PSV of more than 10 centimeters per second. The normal ovaries have RI of ovarian stromal RI of between 0.6 and 0.7 and the PSV of between 5 and 10 centimeters per second, whereas poor responders have a higher resistance and a lower PSV RI of more than 0.7 and PSV of less than 5 centimeters per second. PCO patients have higher vascularization. It is for this reason that PCO patients do hyper-respond. So now, if I put this all things together, remember, it is LH which leads to more stromal flow, and it is LH which leads to stromal abundance. Moreover, it is more stromal flow which is correlated also with the ovarian response. And if the ovarian stromal flow is high, that is when the ovarian response is going to be better. On the other hand, it also means that it has adequate LH. But if the ovarian stromal flow is less, or it is a high resistance flow, yes, it does mean that the ovarian response is going to be poor, but it also means that LH is either low or it is low bioactive, or there is a receptor polymorphism. And it is in this cases that the LH secreted is not perceived by the follicles or by the ovary. And therefore, it is in these cases that LH supplementation is required. So that means LH has a lot of ultrasound signs, and it has a lot of implications, and therefore it gives us a lot of information checking about LH stromal flow and stromal hyperechogenicity or stromal abundance. Coming to estrogen, granulosa cells have big antral follicles, and the larger follicles stimulated by FSH produce estrogen. Perifollicular vascularity of the dominant flow, which starts developing as early as about day 5 to 7, which is mentioned in the literature in the normal length cycle, therefore is an indication that the FSH has started now working on the follicles and therefore on the granulosa cells, and therefore the estrogen secretion has started. Thus, the vascularity of the dominant follicle, of the follicle indicates the dominance of the follicle, and it represents FSH receptor development and rising levels of estrogen, therefore. But this only tells you the estrogen level has started rising. When we are doing ultrasound, we are not just checking the blood levels. I mean, we are just not looking at the secretions. We also want to check the bioactivity, which can be assessed by looking at the endometrium. And the estrogen on the endometrium reflects as increase in the endometrial thickness, change in the endometrial morphology, increase in the endometrial vascularity, cervical mucus, and hyperechogenicity of the cervical glands. So as the follicular growth starts, as the and there's a vascularity documented, which means the estrogen secretion is increasing. This secretion, this estrogen effect must always be confirmed by looking at the endometrium. If I say it so, if you find an endometrium which is thicker than 5 millimeter on the baseline scan and a multi-layered pattern, it suggests high estrogen level, which must be confirmed by correlating with the ovarian status, wherein the ovary may show either a polycystic ovary or a multicystic ovary, or there may be an early recruitment of the follicle. As seen here, you have a thickened endometrium. It may be either a polycystic ovary, which has increased vascularity, or it may be an early recruitment of the follicle. Whereas if the endometrium is thicker than 5 millimeter on the baseline scan, but it is not multilayered, it is high, it has a higher echogenicity, it may be because of high progesterone level. In this cases, you must look at the ovary and confirm the presence of residual active corpus luteum, where I repeat, where there will be a corpus luteum-like structure with hemorrhagic echogenicities with a ring of color, which is low vascularity. This is the same that I told you if I'm talking of an intact junctional zone. But remember, if on the baseline scan you have a thickened endometrium, and the junctional zone is irregular, you must think about acute endometritis. Usually, rarely, it may be adenomyosis, especially in those cases where the junctional zone is not at all clear. And that is where mistakes may occur. It would be the myometrium, which is completely merging with the endometrium, and wrong assessment of the endometrial thickness is possible. Coming to the pre-ovulatory period, estradiol to know the follicular maturity is what we want to check. LH to know the surge has started, and of course, whether it is on time or not, and progesterone to exclude the premature surge. If I said estrogen first, the fall in the perifollicular RI starts about 2 days. I did tell you that the perifollicular flow starts along with the dominance of the follicle. This flow keeps on increasing to gradually cover at least 2/3, preferably 3/4 of the circumference, and it is just 2 days before the ovulation that the RI of these blood vessels, it reaches a nadir. And this absolutely correlates with the final estrogen surge. That means pre-follicular periovulatory RI, perifollicular pre-ovulatory RI correlates absolutely with the estrogen levels. That means that if the perifollicular blood flow is good with a low RI, I would say the estrogen production is adequate from the follicle. So mostly the follicle is a good quality follicle. But it is after that that the PSV of the follicle starts rising, and when it reaches about 10 centimeters per second, that is when the LH surge starts. Not only that, this blood flows correlates with the ovum quality, it also, therefore correlates with the estrogen levels. Ovarian flow correlates well with the oocyte recovery rates and hence may be useful in determining the most appropriate time to administer the trigger to optimize the oocyte recovery rate. Follicles with more uniform perifollicular vascular network are more likely to produce pregnancy naturally because these are better quality follicles because they're producing more estrogen. It is this estrogen, as I told you, which is going to act on the endometrium. The endometrium, which starts becoming multilayered as early as about 6th day of the cycle, is because of the secretion of the estrogen from the granulosa cells of the dominant follicle. As the estrogen level rises, the endometrial thickening increases. It is because of that that you see a typical multilayered endometrium with the intervening area, which is severely hypoechoic or anechoic. This is called a grade B endometrium, usually correlates with estradiol levels of approximately 100 to 300, 400 picogram per ml. That means 1 or 2 mature follicles. Whereas if the estradiol levels are higher, 3, 4, 5 mature follicles up to about 100, up to about 900 or 1000 picogram per ml, you would see an endometrial in the multilayered endometrium with the intervening area, which shows echogenicity, not more than that of the normal myometrium. This is called a grade A endometrium. Whereas if there's a truly supraphysiological levels of estradiol, where there's there's either a PCO patient or it is IVF stimulation, that's where the endometrium will lose its multilayered pattern. It becomes homogeneous. But look at this. It is absolutely isoechoic to the normal myometrium, not hyperechoic. This is also a pure estrogen-dominated endometrium. All these three endometria are good for implantation provided the vascularity is good. And the vascularity, as we know, is the second sign to tell us that the estrogen level is rising. Endometrial and the subendometrial flow increases in the follicular phase, reaches maximum about 3 days before the ovulation in natural cycles, 2 days before the ovulation, same time as the follicular flow starts, follicular RI falls for the stimulated cycles. But very interestingly, another phenomenon occurs. And this RI reaches about 0.6 highest. Just before, when this RI is reached at 0.6, I would say this is an endometrium which has adequate flow, but provided these blood flows, they reach the inner layers of the endometrium. We are now talking about the intraendometrial flow and not about the subendometrial flows. So the vascularity has to reach the inner layers of the endometrium, has to have an RI of less than 0.59. And it should cover at least 5 millimeter square area. That will tell me the estrogen which is produced by the follicle is sufficiently reaching the endometrium, and the endometrium is also adequately receptive. But that's also not enough. If the estrogen is acting on the estrogen receptors in the uterus, that means even the PI of the uterine artery should be less than 3.2. It is at this time that the surge starts, and it means that the follicle is functionally mature and the estrogen is there's an adequate estrogen receptor development, and the estrogen is acting on the endometrium also. Instead of that, if you have a thin endometrium in the pre-ovulatory phase, look at the junctional zone again. If it is intact, it means there's either a hyperprolactinemia or other endocrine affecting it, or there may be sometimes an Asherman syndrome. But if it's an altered junctional zone, you would have the two possibilities, probably adenomyosis or chronic endometritis. Remember that the thin endometrium is a diagnosis only in the presence of a normal follicle with a good vascularity. If the vascularity of the follicle is inadequate, it is an inadequacy of the follicle and not an inadequacy of the corpus luteum. But sometimes it does happen that in spite of a good follicle, if the endometrial vascularity is less, that is when less estrogen is reaching the endometrium and you would still get a thin endometrium. What happens after that? So this is, we have reached the time of the surge. After the surge, there are changes that occur in the follicle and the endometrium both. As the LH surge starts, that's when the vascularity of the follicle increases. The PSV increases significantly. There's a marked increase in the peak systolic velocity surrounding the follicle in the presence of a relatively constant PI, and this could be a sign of follicular maturity. Follicular maturity and impending ovulation. And there are multiple studies indicating the same. It is about 29 hours before the ovulation that the PSV of the follicle increases, remains high for a long time. And we know that the LH surge, which starts about 36 to 42 hours before ovulation, has a slow rise for about 6 to 7 hours, and just about 29 hours before the ovulation, it's going to be a steep LH surge. And the PSV of the follicle correlates with that perfectly. That means that if the PSV of the follicle is high with a low RI, that means you are not at the start of the surge here. You're somewhere here on the surge. There's somewhere here on the surge. That means that the ovulation is not going to occur after 36 to 42 hours. It's going to occur early. And it is in these cases that the earlier ovulation, because the ovulation is going to occur early, the IUI also should be done earlier. And therefore, based on that, a study was done long back. I'm not going to discuss the study in detail, but it clearly indicates that as the PSV of the follicle rises, the pregnancy rates with two IUIs, one which was done 12 to 14 hours, second which was done 36 to 38 hours, the chances of pregnancy is significantly increased, whereas the pregnancy rates with single IUI done at a routine time, 36 to 38 hours, significantly decreases with the increasing PSV. That means with the rising PSV, ovulation is going to occur early, and you should do an earlier IUI in these cases. On one side, where the follicular PSV increases, on the other side, we know that with the rising surge, there is a fall in the estradiol levels, and the progesterone levels are going to start rising even before ovulation, but it will take 4 or 5 days to get to a plateau. That means there's a phase where estrogen, progesterone both are low, and because the estrogen, progesterone both levels are low during that short period of time, therefore the endometrial vascularity significantly decreases during that time. Only after the progesterone rises, the endometrial vascularity again comes up. It is because of the same reason that the uterine artery PI also increases immediately after the surge has started. And it is also during this time that you would find changes in the endometrial morphology immediately after the start of the surge. Because of the compacting effect of the progesterone, you would find fluffiness of the outer margin of the endometrium instead of sharp pencil line-like margins. But beyond 24 hours of progesterone exposure, or beyond the physiological levels of progesterone, you would see hyperechogenicity of the outer margin of the endometrium, which gradually spreads into the inner layers of the endometrium, becomes absolutely hyperechoic and homogeneous only in the mid-luteal phase. That means that fluffiness of the outer margin of the endometrium without hyperechogenicity is a sign of physiological exposure of endometrium to the progesterone. And this is a desired sign before the ovulation occurs or immediately after the ovulation. If I say that it indicates 24 hours of exposure, if you find the signs in presence of ovulation, that means a recent rupture has occurred. If you find this sign which a mature follicle and a high PSV, it means yes, the ovulation is impending. But if you find the signs when the follicle is immature, that is when it indicates premature LH surge. Remember that the endometrium is only a receptor organ to estrogen and progesterone, so you should never find a thicker endometrium in absence of any follicle. If you find that it's either a PCO or you have missed a recent rupture, and in those cases, you must check the signs of early rupture. That means that I've told you already what are the signs of LH surge, what are the signs of early progesterone, and what does it mean when, how to interpret them in presence of a mature follicle, immature follicle, or in presence of already a ruptured follicle. Coming to the mid-luteal phase, there's a clear correlation between the RI of the corpus luteum and the plasma progesterone levels, and has been seen in the natural cycles. RI of the corpus luteum can therefore be used as an adjunct to the plasma progesterone assay as an index of luteal function, even in the stimulated cycles. Ri of the corpus luteum, therefore, should always be. So in the mid-luteal phase, it's only in the mid-luteal phase that you can evaluate the mid-luteal phase, because it's only that you can evaluate the luteal phase, because it's only then that the progesterone level reaches a plateau. And therefore, if you on the mid-luteal phase find that there's a beautiful ring of color surrounding the corpus luteum with a low Ri, it indicates adequate progesterone production. We have to always check its bioactivity. So we look at the endometrium also, if it shows hyperechogenicity and the vascularity reaching the inner layers of the endometrium with a low resistance flow, it tells us, yes, this progesterone is adequately acting on the endometrium. Along with that, if you also see that the uterine RTPA is less than 2.5, that means there's adequate progesterone receptor development. If the progesterone receptor development is adequate, which also means that the estrogen priming of the endometrium was adequate. Based on that knowledge, we can diagnose the abnormalities of the luteal phase. If there's a luteinized unruptured follicle, remember it is luteinized and it is unruptured. If it is unruptured, you will never see hemorrhagic echogenicities inside. But because it is luteinized, you see hyperechoic walls. So hyperechoic walls and low-level echogenicities. And because it is luteinized, but it is unruptured, it produces there's inadequate conversion of granulosa cells to thicker cells. It's because of that there would be inadequate progesterone production. If the progesterone production is inadequate, therefore the Ri of the structure is going to be higher than the normal corpus luteum. Therefore, if you find in a mid-luteal phase a cystic lesion with low-level echogenicities, hyperechoic walls, and inadequate, scanty flow or a high resistance flow, it indicates it's a luteinized unruptured follicle. Because it's a luteinized unruptured follicle, inadequate progesterone production, so the endometrium will show initial compacting effect, but it doesn't grow beyond the pre-ovulatory thickness, and it shows scanty or a high resistance vascularity with a uterine RTPA of usually between 2.5 and 3. So that is a luteinized unruptured follicle. But very interestingly, there's one point which I want to tell you, and that is, remember that a luteinized unruptured follicle is of a significance only in absence of any corpus luteum. If you have one corpus luteum, any number of luteinized unruptured follicle is not a problem at all. Coming to the second condition, which is a luteal phase defect, usually due to inadequate corpus luteal function or a corpus luteal failure. If the corpus luteum has failed, that means now you have a cystic structure which has hemorrhagic echogenesis, it is non-hyperechoic walls, but still has a scanty flow. This is an inadequate corpus luteum. And if this is inadequate, that means progesterone production is less, the endometrium is going to be thin, it is not going to be hyperechoic, it is going to be hypovascular, and the uterine RTPA is usually going to be more than 3. This is a luteal phase defect because of inadequacy of the corpus luteum, whereas if you get a normal corpus luteum, but if you still get an inadequate endometrium, this is a luteal phase defect because of inadequate progesterone receptor development. In this case, you are going to support the corpus luteum in the next cycle. In this case, you are going to check adequate estrogen priming and also adequate flow to the endometrium in the follicular phase, and you are going to correct that into the next cycle. Remember, luteal phase defect or luteinized unruptured follicle in one cycle is not going to be in the every cycle, because it's every follicle which is different, and therefore every follicular phase which is also going to be different. To summarize, early recruitment of the follicle, increased FSH, increased endometrial thickness, high estrogen or progesterone, increased stromal flow, high LH for a short period of time, increased stromal echogenicity, high FSH and anovulation, more antral follicles, high androgen, high AMH, and high uterine artery resistance, high androgen. Whereas on the pre-HCG scan, good perifollicular flow tells you good estrogen production naturally, therefore inadequate flow tells you inadequate estrogen production. Good endometrium with good endometrial flow and cervical mucus tells you adequate estrogen receptor development in the endometrium. Fluffy endometrial margins tell you about early exposure to progesterone, increasing echogenicity of the follicular wall, and increased RI tells you about the premature LH surge. Whereas in the luteal phase, low corpus luteal RI tells you about the normal progesterone production, high endometrial vascularity tells you about adequate progesterone receptors, low corpus luteal vascularity, luteal phase defect because of corpus luteal inadequacy, and low endometrial vascularity, inadequate progesterone or inadequate progesterone receptors. Thank you very much for the patient hearing.
Thank you so much, ma'am. Excellent presentation, ma'am. Covered all aspects thoroughly, ma'am.
Thank you.
Prayers for speedy recovery of sir, ma'am.
Thank you very much. Thank you very much, all of you.
Thank you so much, ma'am, for your wonderful, enlightening, and very lucid lecture, ma'am. I'm really very thanks. You are so committed, ma'am. And I pray to God for the recovery of sir. Thank you so much, ma'am.
Thank you very much.
Dr.
Thank you.
Thank you. Dr. Varuni, are you there? So thank you so much, ma'am.
Thank you.
Yeah. So move on to our panel discussion. The topic for today is the eyes cannot see what the brain doesn't know, the interpretation, follicular, and endometrium. So for that, the expert is Dr. Tina Gupta. She is director of Asha Punch Fertility and Gynec Center, Bhopal. She is currently the treasurer of IFS MP chapter 2022-26. She is recipient of IFS Achiever Award for Division 23. She has done diploma in IVF and reproductive medicine, Kiel's, Germany, diploma in gynecology. She has received many awards. She's an ex-registrar, IVF and reproductive biology units, Maulana Azad Medical College, and she's received Dr. Reddy's Gold Medal. I welcome Dr. Tina.
Thank you. Thank you, Sonali. Yeah, now I would like to introduce Dr. Sonali, my dear friend. She is a laparoscopic and IVF specialist from Agrawal Hospital and Research Institute, Gwalior. She is executive member, Indian Fertility Society, Joint Secretary, Gwalior Obs and Gynae Society, 2018-19. She is treasurer, Gwalior Obs and Gynae Society, regularly organizes live surgical workshops in Gwalior. She has been guest faculty at various state and national conferences. She has received Chikitsa Ratan Award 2017. She has done various fellowship courses in cosmetic gynecologies, fetal medicines, and fetal imaging academy courses. She has also received infertility training from Singapore and Mumbai, and she is trained for laparoscopic surgeries at AIIMS, New Delhi.
Thank you, Dr. Tina, for your kind words. So now I will introduce our today's panelist, Dr. Nidhi Mishra, madam. She is currently working as a consultant obstetric and gynecology laparoscopic surgeon, sonologist as Seva Hospital, Sagar. She has received many awards. She's working as an assistant professor in Department of Obstetric Gynae, Bundelkhand Medical College, Sagar. Our next panelist is Dr. Monica Jain. She is obstetric and gynecologist and sonologist at Mira Hospital, Sagar. She is a past secretary, IMA Sagar, and past president, Sagar Foxy. Next, our panelist is Dr. Archana Srivastav. She is currently working as obstetrician and gynecologist, Shri Siddhi Vinayak Hospital, Sagar. Dr. Rupali Jain. She is pursued MBBS from GRMC Gwalior, DGO from MGM MC Indore, working as obstetrician and gynecologist at Sagar. Prasutika Greh Sagar. She is the past president Foxy Sagar 27, secretary of Foxy Sagar 2010. Dr. Smita Dubey is currently working as an obstetric and gynecology in Kilkari Hospital, Sagar. She is the past secretary and president of Obstetric and Gynec Society, Sagar. Special interest in adolescent. And our last panelist is Dr. Smita Dubey. She's consultant, Kemchand Jain Charitable Trust Hospital. She is secretary of Sagar Obstetric Gynec Society, 2009. She was the president of Sagar Obstetric Gynec Society, 14-15. I welcome all my esteemed panelists. So let me share my presentation. Give me a minute. So these are the follicle development that madam has taken very well in our lecture. So we directly jump on to our panel questions. So this is our question. This is the image which is taken to measure the endometrial thickness. So what is the correct way of measuring endometrium? Dr. Nidhi?
Yeah. And the correct way of measuring the endometrium is to measure it at a perpendicular plane at where the thickness is maximum, and from the border of the myometrium and endometrium, or on both the sides, from one border to the other. Endometrial myometrial junction, from one endometrial myometrial junction to the other endometrial myometrial junction, perpendicularly in a perpendicular plane, and at the site of maximum thickness of endometrium.
Right. Dr. Archana, Dr. Monica, would you like to add something?
So if there's something filling, some fluid is present in the endometrial cavity, then we have to exclude that fluid. We have to measure the thickness on both the sides.
Right,
Right,
exactly.
exactly.
Excuse me.
Excuse me.
The maximum area.
The
Hello.
voice
Voice is echoing.
Excuse me.
Excuse me.
Am I
Am I audible?
Mr. Shiva?
Mr. Shiva?
Yes, ma'am.
Yes,
Someone
ma'am,
has
someone
joined
has
with
joined
two
with
devices,
two
I think.
devices, I think.
That's why I
That's
just.
why I just.
Okay.
Okay, my request,
Mute one
mute one
device.
device.
That
That
echo will go,
echo
I
will
think.
go, I think.
So these are
So
the
these are
points
the points
for
for
look for the endometrium by transvaginal ultrasound. It should be in a sagittal plane, and the endometrium, when we are measuring it, endometrium should be perpendicular to the probe. Its image should be magnified. This is a very important point. We should magnify the image, and we measure the thickest portion, outer to outer, perpendicular to the endometrial midline, and we do not include endomyometrial junction, and we measure in millimeter. So very well pointed out by Dr. Nidhi.
Dr. Nidhi.
Move on to our
Move on
second
to our
question.
second question.
What is the
What is
importance
the
of
importance of
Ma'am.
data
Ma'am.
or baseline
or
scan?
baseline?
Excuse me,
Excuse me,
Dr.
Dr.
Archana.
Archana.
I think
I think
something
something
from the.
from the.
Request Dr. Archana
Request
to
Dr. Archana to
stop
I
one
have
device.
stop one device.
Voice is echoing.
She is only with one device. I think some audio glitch from their side. That's why if I am muting Archana ma'am, then echo is going already.
Madam can sign out and then again log in again. I think that can
Yeah,
rectify the
yeah, I
problem.
think.
Requesting Archana ma'am.
I think that's fine now.
Yes, it's better.
Okay now. So, Dr. Smita, can you take this question?
Yes,
Yeah.
ma'am.
What is the importance of day 2 or baseline scan, day 2, day 3?
Yes, ma'am.
Right.
Day 2 scan is a very important scan because we always see for if there is any pathology in the uterus, any adenomyomas, fibroid, or anything else, any pathology in the ovaries, we can rule out that. Then we can do a antral follicle count, and we can also look out for estrogen endometrial thickness. And if there is any residual follicle of the previous cycle, we can always think about that if it is a new follicle or a residual corpus luteal cyst or the previous follicle which has not ruptured in the previous cycle.
Exactly. Very well said. So day 2 scan, because it's called baseline scan, as the all the hormones like FSH, LH, E2, P4 all are on their baseline. So we assess the ovary and endometrium. We look for the size, shape, location of the ovaries, antral follicle count, and we also look any residual cyst. As Sonal madam has very beautifully explained all the points, what we are looking for the any residual cyst on day 2 or day 3. So we look for the color flow, whether it is vascular or not vascular, and simultaneously look for the endometrium also. And we look for the echogenicity, and we look ovarian volume and stromal flow, and we check the shed off of endometrium, and should be less than 4 mm. So there's another question, Dr. Ruby, if you can take infertile patient on day 2 baseline scan. If you see simple cyst, any follicular or corpus or follicle, how will you differentiate and what you will do next? Hello?
Actually, to differentiate, we will see whether it is follicle or corpus luteal cyst. So if size is more than 10 mm, then it will be follicular cyst, and then we will see flow. Follicular cyst will not show any kind of flow, while in corpus luteal cyst, it will show flow, and the walls are very thick, and thick echogenicity we will see. So by this we can differentiate between
We
follicular
can
and
also
follicular
see
cyst.
the endometrium, ma'am. We can see whether the endometrium is thick or not. If it is a corpus luteal cyst, then the endometrium will be thickened in the baseline scan.
Right. So first of all, we have to see the echogenicity and whether unilocular, thin wall, smooth wall. It can be a simple cyst. If it is simple cyst, usually doesn't have any flow around it. If we are looking for the corpus luteal cyst, it has definitely thick wall, and there is a beautiful peripheral vascularity, and this called ring of fire sign on Doppler. And if you see the margins and hemorrhage inside, definitely it's a corpus luteal cyst. When a follicular cyst size is usually more than 2.5, 25 mm, and maybe thin walled and unilocular, and typically looks like a follicle. And we also look for the any chocolate cyst or any endometrioma is there or not. We can see on ultrasound and differentiate. So the next question is, what will you do next? Would you like to, like if you're doing IUI cycles, would you like to stimulate the patient or give CC or letrozole? If you are seeing any follicle, how will you proceed? Dr. Nidhi or Dr. Monica? Anybody can take this
We
question.
will do a sebum estradiol level and then decide.
I will better go with natural cycle because it may hamper our sight or our vision in if we stimulate this cycle and do frequent ultrasound, then we may be confused or sometimes we won't get the good results in this case. So we may go for the natural cycle and the next cycle after giving we will control the cycle by giving her contraceptive pills, and then we can stimulate after 2 or 3 months after giving the pills. This may be my opinion. I don't know whatever you say.
That is the beauty of panel. So we can have different opinions. Dr. Tina, would you like to comment?
See,
Is
if
there
the cyst-
really required OC pills?
If the
Or
cyst is
how
vascular
will you-
and its size is large, like it's more than 1.5 centimeter, the cyst is vascular, then this means that the cyst is secreting the abnormal hormones. If it's follicular cyst, then it might be secreting estrogen. And if it is corpus luteum cyst, then it might be secreting progesterone. So better not to go for an IUI or IVF in the present cycle. we can advise the natural intercourse in the same cycle. Or if we find that the cyst is very large, then we might give her OC pills or progesterones to suppress the cyst in the present cycle so that we have a good outcome in the next cycle. Otherwise, the cyst will persist in the next cycle also.
So I differ here. I think cysts usually go by itself, whether you give OC pills or not. So I think it's like individual choice. But I usually don't go any OC pills, and we follow. If this cyst is having corpus luteal and it is active and it is showing endometrial thickness, which is around 5, then better not to stimulate because it's an active cyst. And when we are seeing follicle or any residual cyst which is having low flow and endometrium is well thin, then we can go ahead without any doubt. We can stimulate directly. And in IVF, if you're doing antagonist cycle, you give, if you're suspecting any active cyst, you can give 2 antagonist injections, because this injection antagonist cause luteolysis of the follicle. Or you are doing long protocol, already you are giving the gonadotropin GnRH. So you wait for 2 or 3 days and then see for the estrogen whether it is decreasing. Then you can start after 2-3 days. So this is the question for infertility patient on day 2 scan. If thick endometrium, that is more than 4 and 5, what will you do next? On day 2 scan, if you are seeing thick endometrium, Dr. Nidhi?
On day 2 scan, if there is a thick endometrium, then most probably this patient is going to end up having a shorter cycle. So it is not going to have, we are not going to have good result if we are planning to stimulate this patient. So if we have a thicker endometrium on day 2 scan, then I think we should not stimulate this patient in this cycle and wait the next cycle.
Would you like to wait for 2 more days? Or to recheck by ultrasound whether it's shedding, or sometimes on day 2 scans, it is.
Yeah, sometimes there is a delay in the endometrium and the days of the scan. So we can wait for 2 days and then follow up again.
And always correlate with the ovaries, if they're having any active follicles or not.
Cyst or anything else.
If there is a corpus luteal cyst, then
Cyst
there
or
are
not.
chances of endometrial hyperplasia.
Right. So we wait for 1 or 2 or 3 more days and then rescan these patients and rule out any polyp or any endometrial hyperplasia when we are doing on day 9 scan. If you are suspecting any pathology in endometrium, then rescan on day 9, because polyp is very well delineated when in a proliferative phase, and we can pick the polyp in that day. And still there is hyperplasia, then of course we can do biopsy of this patient, or if polyp, then polypectomy.
And I would just like to add one more point here.
Yeah, Dr.
Like small polyps are sometimes seen on day 2 just as thick endometrium. We are not able to find the proper delineation. But as we keep on continuing the follicular scanning, then these polyps become more prominent. On day 2, they are just apparent as just thick ET. So we should always keep in mind on patients of thick endometrium and there is no ovarian cyst. It can be a patient of endometrial polyp also, small polyps.
Right, very well said. So this is the patient, infertility patient on day 5, deep transvaginal scan. Follicles already 18 mm, but endometrium is 5 mm. So what you will do next in natural cycle and IVF cycle? Dr. Archana? Are you there, Dr. Archana? Dr. Smita?
She's not there.
Ma'am, 18 mm follicle on day 5, we should first rule out, we should put a color Doppler and see if what is the blood flow. Because is it an active follicle or not, we have to rule out that. And if it is an active follicle and endometrium is 5 mm, I think we should wait for the natural cycle and do IVF or some other procedure in the next cycle.
Right. Dr. Monica, would you like to add something?
If follicle is 18 millimeter and it's only day 5 and endometrium is thin, so it's not going to, if it is a good flow follicle, then we should discard either this cycle. We should not go for the any stimulated cycle or IVF or IUI. We should go for the natural cycle, and we can give her this estrogen tablets. If and we follow this cycle, and estrogen tablets can be started, and we can follow this. If any other follicle is increasing or something else, that can be, we can watch, because we have started follicular study, so we should continue and watch this cycle, and we can accordingly we can plan in the next cycle according to this study. This
But
will be the
as I think that Sonal Panchal madam told us that if it is follicle is increasing and if it is very high FHS, then we should not wait for any cycle to get waste. We should use that cycle also for IUI. So we should rule out about if the ovary is aging or not, and look for the color flow Dopplers and other things in the flow also.
Right. Dr. Tina, would you like to conclude on this?
Yes.
As
Yes, this is basically the early follicular recruitment, and this is a typical sign of ovarian aging. Nowadays, we are seeing so many patients of decreased ovarian reserve, even at the age of 25 years, 30 years, we are seeing so many patients. So in these patients, we should be very cautious that even a single cycle is important. Though we always have an assessment of the ovarian reserve when we start the cycle from day 2, we always have in our mind that this patient might behave like this, that she might have poor ovarian reserve. So especially in these patients, if the follicle recruits early, we should counsel the patient that see your ovaries are aging. So we need to shift to the higher treatment possible as early as possible.
exactly my point. I think if we are seeing very good follicle at day 5, means it has started, FSH is high and it is responding well. And this is happening when ovaries are aging. And these are the few literature says if you're doing high CCQ doses or letrozole doses of gonadotropin, in that condition also you can get this mismatch in this. So, Dr. Tina, would you like to add estrogen?
Sorry, Sonali.
Would you like to add estrogen to catch
In the,
up the
in the previous cycle, in the luteal phase of the previous cycle, we can add estrogen in these patients so as to avoid the premature ovarian recruitment.
No, I'm talking about this cycle. If it is day 5 and follicle is 18.
No.
And endometrium is 5.
Because since the follicle is already 18 mm, the follicle is secreting sufficient estrogen to form the endometrium. It's just a matter of time that the body endometrium is not getting the proper
So I think
time.
we can wait for 2 more days, to make it 20 mm and then see the endometrium.
Yes.
So I think that we can do, but I would not like to add estrogen at this point of time.
I also don't add estrogen in these kind of patients.
Right, because it, yes. So here's the question: ovulation induction by letrozole or CCQ on day 9. Transvaginal scan shows follicle of 18 mm, but endometrium is 4 mm. So anybody can take this. So what next would you like to do?
I mean, I think,
It's
ma'am,
day
we'll
9.
have to, we'll wait for 2 days more to see whether the endometrium is improving or not. Because the endometrial blood flow is not very good, therefore the endometrium is thin, so we can wait for natural progression of endometrium for 2 days more.
Ma'am, I think because it is already 18 mm and if we trigger, we should look for the Dopplers, and if the blood flow and perifollicular blood flow is all right, then we can trigger the cycle, and by that time the ovulation is happening, the endometrium has time to grow more.
Okay. Any other panelist?
Maybe ma'am, post-BLC patient may be having Asherman syndrome, or as Panchali madam said, endometriosis, endometritis may be responsible for thin endometrium.
This
So we
usually
should have
happens
DNC, past DNC from the patient.
past history.
So,
Even
Dr. Tina?
clomiphene citrate use also causes thin endometrium. So we can shift this patient to another form of stimulation in the next cycle.
I would like to ask our expert to conclude. Dr. Tina?
Yes, yes, Sonali. See, the follicle is 18 mm and endometrium is 5 mm. So basically,
it is 4 mm.
Follicle is 18 mm and endometrium is 4 mm. So follicle is growing, but the endometrium is not growing in proportion to the size of the follicle. So basically, this means that estrogen, which is produced by the follicle, is not enough, is not proper for the maintenance of the endometrium. So this can be seen especially in cases of CC cycles. For the next cycle, we need to change the protocol. If in the present cycle, we are using clomiphene citrate, since it has anti-estrogenic action on the endometrium, for the next cycle, this patient is for letrozole. There is much less to offer in the present cycle. We can follow up the patient for 1 day or 2 days more. But in the present cycle, there is much less to offer her. Though we can add ecosprints and other vascular enhancers, but all these have empirical role and no proven benefits for these.
Ma'am, what is the role of sildenafil in this? Can we add sildenafil?
We can add this, but there is no proven role for this. All these things have empirical role.
Right. Very well said, Dr. Tina. So move on to our next question. Day 10 follicle increased in size till 23 mm and endometrium is triple line. So what next would you like to do? Dr. Monica, would you like to trigger?
I would like to trigger it and we'll follow up this cycle. But first, we will see the perifollicular blood flow. If it is good and the follicle is nice, then we can go for trigger. IUI we can do or not, but trigger I will give.
Right. So we should see all the endometrium and flow and everything, and then we decide with though it is slightly higher side, the follicle size. So we would like to trigger this patient with HCG and then follow. So this is the one patient, infertile patient on day 12, follicle is 27 mm and endometrium is security. So I would like to ask Dr. Rupali, she's there? No. Dr. Smita?
Yes, ma'am.
What will be your diagnosis?
And it's luteinized unruptured follicle.
It is unruptured follicle, maybe because endometrium has already has come to secretory, like endometrium is already looking secretory. So it is an unruptured follicle. So we can abandon this cycle.
Okay.
And
Or
ask them to have natural intercourse if they conceive by themselves.
Right. If it is a natural cycle, it can be a type of corpus luteum, and we can ask them to wait and not jump on the diagnosis of LUF, and patient can conceive. If you are following this cycle and if you have induced, then we can definitely say it's a LUN. So my next question is, what are the causes of LUF, luteinized unruptured follicle? Dr. Ruby, can you elaborate the causes of luteinized unruptured follicle?
Again, the use of clomiphene citrate and GnRH analogs and sometimes
endometriosis, pelvic adhesions, non-steroidal drugs, NSAIDs.
Usually the endometriosis and adhesions, which is blocking the ovulation, which is not, there is a pelvic adhesion and inflammation, which is because of which the ovulation is not happening. So these are the main reasons for LUF. I would like to ask our panelists any role of mid-luteal scans. If it is, then when and why? Dr. Nidhi, would you like to take this question?
Yes, ma'am. The mid-luteal scan we usually do to see whether the endometrium.
Are you doing routinely this mid-luteal scans?
No, we rarely do it, ma'am. We are basically, we are not into infertility practice so much, so we do basic follicular scanning only. So mid-luteal scan, I have never done. Yeah.
So directly, what are the indication of doing the mid-luteal scan?
What I have read, it, ma'am, that if we do a mid-luteal scan and if the RI is still less, then there are chances of conception, and we can rule out if it is a corpus luteal defect, or if she's conceiving or not, we can make out from that. And if the RI increases, that means that she has not conceived in that cycle.
Right. When there's a
And by
really a case of
by mid-luteal scan, we can assess corpus luteum and
The
endometrium
function
and
of
use
luteum,
an
that is.
RPI.
The level
So
of
for better
progesterone
assessment of
and the endometrium. So the what are the rates of what is the chances of implantation, proper implantation that can be assessed?
Right. So to check the size and appearance of corpus luteum or its flow, so we'll well developed and producing the adequate progesterone to support the potential implantation is done in infertile patient with a history of early pregnancy losses or not conceiving. It is done around day 12, that is a mid-luteal cycles on a 28-day cycle women. And when a luteal corpus luteal size is large, well-defined, the corpus luteum is usually considered as a positive signs. When echogenicity and internal textures of corpus luteum and vascularity is good, then it is considered a normal. A normal finding of corpus luteum is it's well-defined corpus luteum indicates adequate progesterone production, which crucial for the successful implantation. Abnormal findings are when a small or poorly developed corpus luteum and which is having low flow, you can suggest a corpus luteal defect. Though we have to further potentially correlate with the progesterone level at that time. So it is combined with the progesterone level if you really want to say this is a luteal phase defects. So these are the few causes which can cause reasons for LUF. So Dr. Smita, what are the ideal criteria of giving trigger? Like when you are confident like this patient is ready for prepare, all the criterias of giving trigger.
When the follicular fluid and the endometrial halos and edema are seen, when the blood flow around the follicle is 3/4, it is the blood flow is covering 3/4 of the follicle. When the RI is less than 0.5 and PSV is more than 10.
These are the parameters.
The size of the follicle. Size of the follicle is
cumulus,
also
presence of
size is
cumulus.
obviously definitely
We
more
see
than
the
18 mm.
endometrium also.
Presence of cumulus is
16 to
very
18
important.
mm. Size from 16 to 18 mm.
It also depends on the type of the
Type.
stimulation protocol we are using. The size also depends on that.
Right. So these are the measurements and these are the criteria. When we said now we can confidently give HCG. So this is the one case, patient on day 11, dominant follicle 18 mm, RI is less than 0.48 and PSV is around 6 to 7. So endometrium is 8 mm, 999, but poor flow. So Dr. Ruby, would you like to give trigger in this patient?
Ma'am, in this case, there is because flow is very poor, so there is poor chances of implantation.
I think
So,
we'll wait for 2 more
We
days.
wait for 1 day. We will wait for 1 day and
As
we
it
assess
is
the
18
patient.
mm only, we can wait for 1 or 2 days, and then if these parameters are better, then we can give a trigger. Patient on day 10, dominant follicle is around 18 to 19 mm, RI is 0.5, PSV is more than 15, uterine artery PI is more than 3.2, endometrium 7 mm, but 999 with a good flow. Dr. Monica, would you like to? Hello, Dr. Monica, would you like to give trigger in this patient?
Yeah, I can wait for 1 day and I can give trigger. But I can give also same day because flow is good, follicle size is good, and
We will directly give the trigger as all the
PSV.
yeah, I
yes,
can directly
yes, because good flow is there and size is already 18 to 19 mm.
Yeah, 18 to 19 is best.
Endometrium is 7.
And peak
Yes.
systolic
Right.
velocity is more than 10. So we always think that the surge has already started in this case.
So we can give trigger in this patient. So this is the patient on day 11, dominant follicle 19.9 mm and PSV is 7 and RI is more than 0.45. So what do you suggest? What is your diagnosis? Dr. Monica or Dr. Nidhi?
Poor flow of endometrium is there.
The poor flow.
What is the endometrium parameters in this case?
Endometrium is normal.
The
It's
PSV
triple.
is
LUS going good.
Yeah.
LUS,
It's
but RI is
less.
more. PSV is less. So
RI
it is
resistance is more. Already size is more than 18 mm and it's day 11. So most probably it's a utilized unruptured follicle. So anybody can take this question, role of color Doppler in folliculometry, but madam has taken wonderfully. So anybody can summarize all the. So we have to see vascularity and if it is more than 3/4 or more than 75% of the follicular circumference, it is considered as a good follicle. And it is a good time we can give a HCG. So these are the parameters which we can find out whether this is the right time to give HCG trigger in this patients. So these are the all the newer areas which madam has mentioned in her lecture. So to conclude, the synchronous follicle growth with endometrium is very important. We should start with the slow doses and then we should follow. And with increase in a small doses, the critical time for trigger for adequate LH surge is important. The appropriate choice of injection of trigger should be given. The right amount of doses. Avoid premature LH surge. Avoid premature luteinization. Constant looking for the endometrial quality in the development of to have a good functioning endometrium for implantation. Appropriate high amount of luteal phase support should be there. And the production of a viable embryo requires the ovulation of a complete competent oocyte, adequate progesterone production by the corpus luteum and adequate endometrial environment. So thank you so much, my esteemed panelists, for wonderful interaction and active participation. So thank you, Dr. Tina, for your expert
Really, you have
comments.
taken all the possible varieties of cases and summarized their answers so beautifully, actually, I would say. You have not left even a single point in the answer slides.
Thank you so much.
It was a very interesting discussion.
Yes,
ma'am.
yes,
Thank you
yes.
very much. So we have learned a lot from this discussion today.
Thank you so much, my everyone here, all the chairpersons, Dr. Ramti Madam and Dr. Swati has joined, and all the chairs, the guests over here, the chief guests, all the Mr. Corner, Madam, everyone were here, and my dear participants for making this event successful. Thank you.
Thank you.
Thank you, Sagar. Next slide, please, for participation and all support. Thank you so much. Mr. Shivam, I think we can stop now.
Yes, ma'am.
We are with, so I'm very happy to manage time. Thanks, everyone.